Hello, everyone, and good evening, Europe, good morning, US, and good night, Middle East. We are here today with a very good friend of mine, a very good skilled operator, vascular surgeon from Bilbao, August Aiza, and he's going to talk to us for the 17th episode of Vascupedia Views Fem-Pop edition about tips and tricks in the treatment of restenosis of the femoropopliteal segment. So it's a very interesting topic, actually, because it's something that we need to deal with after sometimes our intervention, so how to change our strategy or what was better to be done before. So there's a lot of inner also understanding of what you do during your everyday life, and who is best than August to talk to you about this. And I just want to remember you that as from our Vascupedia Views format, we will have this of course the polls, and the polls will be out during the presentation. We're going to ask you to vote for your best option, and your best option then will be discussed at the end of the presentation by me and by Dr. Aiza. And I just want to remember, whoever is on the mobile phone, you need to come out from the full screen view and then to be able to vote. So I already spent too much time in introducing this phenomenal colleague. So August Aiza, the microphone is yours. Please tell us everything about your tips and tricks.
Oh, thank you so much, Lorenzo. You know, I really love to be a part of these amazing educational sessions. I really love to be a Vascupedian. So let me start with this pic that I took from you. This is Erasmus of Rotterdam, and I definitely think
share screen.
This quote. Oh, sorry.
Share your screen. Yeah,
no worries. I was there.
I know that you could entertain us even just with your voice, but to see the images is even better.
Okay, I will try. Otherwise, I will ask you to do some.
Yeah, like, you know, it happened to me once at VIT, where my presentation completely stopped. So I finished by talking through the slides without seeing them. Yeah, you were there. Okay. Here we are. Yeah. Okay. My big face there.
So here we are. Yeah, definitely. I was saying that I definitely agree with this quote by Erasmus of Rotterdam, who stands that prevention is better than cure. And this definitely can be applied to the treatment of restenosis on the Fem-Pop segment. But I also agree with this quote of Lorenzo of London, when he qualifies that, yeah, definitely prevention is better than cure, but if you do it right the first time. And at that stage, let me just publicly thank you, Lorenzo, because as you know, I had a lot of issues with my files of images, and you have been really kind to share with me some of your cases for this presentation. And what do you think? Shall we just jump to the first poll, straightforward?
Let's do it. Yes, the first poll. So guys, it's probably a preliminary poll. And the question number one, we invite you all to vote. What is your primary vascularization method for long SFA stent occlusion? So, you know, probably we'll see the Tosaka classification. So occlusion is related to very bad outcomes. So what's your approach? POBA? So simple angioplasty, option number A. DCB, option number B. So you pass a wire, you inflate a balloon, either plain angioplasty or DCB. C, bare metal stent. So you reline the thing with a bare metal stent, or you reline the thing with a stent graft, for example, the Viban stent. And the last option is debulking plus or minus DCB. Very good poll, I think, August, and then now we're gonna see, you know, why people probably should choose something compared to another option. So please go ahead. Thank you.
Okay, so if we talk about prevention, I always wonder if you can effectively prevent stenosis or occlusion, because so far nobody has been able to predict which patients will develop intimal hyperplasia or in stent restenosis, regardless having treating them primarily with drug-cutting technology. And on the other hand, we have this bunch of avoidable factors that are inherent to the decision-making process that may interfere with the good outcome of your procedures, such as case selection, suboptimal vessel prep, and inadequate device selection at specific spots like P1 or P3 segment. What about biomimetic technology? Or a non-accurate analysis of our outcomes. And from my point of view, I definitely think that we should face these factors, because if you can minimize the impact of these factors, your results will definitely improve. And if we are completely honest, we don't actually work always in an ideal scenario. We all have very busy agendas, with really always in a sort of hurry. We don't always have enough time to carefully review our completion angios, to assess what is the weight of a residual dissection, or to spend the extra recommended 50 minutes to see if we have the famous recalling effect, up to 30% restenosis in more than 90% of the cases. And sometimes we even try to convince ourselves with what we call self-reinforcing sentences that the outcome is more or less acceptable. So let me show you one example. So this is a quite straightforward case in which we had severe stenosis at the distal aspect of the SFA. So we predilate the vessel and deploy a 5 mm drug coating balloon with a nice outcome. We were really happy. The patient recovered distal pulses immediately, but 24 hours following the procedure, everything went down. So if we go backwards to the completion angio and have a close look, we have this blurry image there. And I remember well the sentences that were said at that point in the OR. We had like, oh man, what a brisk flow. Or sentence like, nice contrast washout. Or my favorite one, yeah, has a dissection. But don't worry, it's definitely no flow limiting. But if you have a close look to the image, you will see that at least this dissection is a type C dissection. And as we learned from the former presentation in these sessions of Fem-Pop Vascupedias from Michael Lichtenberg, what it may seem a benign dissection in 2D imagings may be more threatening under intravascular ultrasound imaging. And if you have a look to Kobayashi's dissection classification, anything higher than a type C dissection will have a poorer outcome compared with a type A or a type B. So at this stage, let me ask the audience a question with regards dissection.
So here we are with the second poll. Then yes, so the question number 2, do you use the Kobayashi's dissection classification in your daily practice? And the option 1, of course, is yes. The option 2 is also no. And the option 3 is like a sort of no, but Koba what? Okay, good. So yeah, let's see what the audience will say. I strongly invite you to vote and then to share your approach. There's no right or wrong. We're just here to learn from each other. For example, for me, it was Kobayashi Watt. You know, I knew about this classification from 1985, which was quite old, but you know, it's always good to know new names and new classifications to have them better in mind. So don't be shy and vote. And August, please continue with your fantastic presentation.
Okay, let me show you another case of not the best planning. So this is a more difficult case, flash occlusion of the SFA, heavily calcified vessel. So we thought, okay, let's try to save time. Let's go straightforward through a subintimal dissection. Unfortunately, we couldn't re-enter distally, so we performed a retrograde puncture of the P1 segment. But as you can see on the image, both catheters are quite separated. And in fact, they were so separated that we tried to perform a cut and we failed. But anyway, nevertheless, we eventually managed to connect both lumens with a nice rendezvous. We predilate the vessel, deploy a stent, and this is what we consider a more or less acceptable outcome. But if you have a look to the pre-op CT scan, you will see that the calcium distribution pattern in this specific case of heavily calcification was mainly located within the arterial wall rather than the typical chunks of calcium or popcorn pattern. So I would say that probably crossing subintimally was not a good choice. And moreover, you have a look to the completion CT scan, you will see that what we consider in 2D imaging more or less acceptable is far from being acceptable, since the stent is compressed in the axial view of the CT scan in different spots. So I would definitely say that our vessel prep was far from being the best one. So if we talk about vessel prep, as you know, there are different types of modality: angioplasty balloons with the specific balloons like non-compliant balloons, scoring balloons, or cutting balloons, debulking devices, atherectomy, rotational, directional, orbital, or laser, and finally IVL. But I'm not going to spare much time talking about them, have been extensively presented in former episodes. I will jump to the non-codified modalities, and the first one is the popping and cracking technique, well known. And it consists in deploying a cover stent plus aggressive balloon dilation with a non-compliant balloon. And this is simple, it's safe, and really effective because the cover stent prevents bleeding or the potential bleeding secondary to the arterial rupture. And moreover, allows a very aggressive balloon dilation, even larger than the nominal diameter of the vessel. The second one is the technique described by Shigeo Chihashi, the Japanese guy who uses a needle to externally fracture the plaque. So let me show you an example of the Pierce technique. This is a case in which we prep the vessel, deploy our super stent, post-dilate, but as you can see on the screen, there were areas where the stent was suboptimally deployed because where the plaque was more complex, the stent was slightly elongated. So at this point, what we use is the Pierce technique in order to fracture the plaque and then post-dilate it. And as you can see in the completion angio, this is a highly effective technique with a nice lumen gain. But some of you may probably think, wait, is there any way to avoid this supermal deployment? Well, we're lucky enough to have today Lorenzo here with us, who taught me a pretty nice technique to sort out this complication. So I would say probably you are the best guy here to explain your own technique. Lorenzo, go ahead.
Oh, thank you, August. I mean, it was a nice case actually, with a long popliteal occlusion from let's say the Hunter canal till the trifurcation. And actually, this was crossed by bidirectional approach, so from the antegrade and from the proximal anterior tibial artery axis. At some stage, I inflated a 5.5 millimeter balloon, and you see here the stent. And the stent looks like, the supera stent looks like enormously elongated. This I couldn't really imagine because when I did everything on the anteroposterior view, I dilated my 5.5 and actually it looked good. So when I do the let's say the completion angio before deploying the stent, there was something which looked very much like a dissection. As you said, it didn't look like particularly bad. Of course, I wanted to stent the whole thing. This was a guy who had 2 bypasses in the past, so I wanted to fix it properly. But at the same time, I didn't see this bloody anterior calcification, which was obstructing then the flow very much. So when I started deploying the stent in a normal anteroposterior view, I saw the stent elongating enormously, but I couldn't even understand why. So this is an image taken with the tube lateral position, and you can see how the stent is enormously elongated. So at that stage, I said, what should I do? Should I leave it like this? You know, I didn't have many options. So either to put probably, I don't know, a balloon mounted stent, but it was not perfect for the popliteal segment, or I thought, as the video shows, that the stent, supera stent is a bit different, so you can elongate it and you can pull it very nicely. So I thought, you know, why not to, you know, use this kind of special stent to be retrieved. So what I did, I just pulled back the stent. And you can see here, you know, the stent was just deployed partially, and I removed the stent. Then I produced like a better, far better vessel preparation. Now that I saw that there was this kind of anterior plaque, so I used a conquest balloon, and you can see how it cracks through the artery. You can see how I created what I called a penetrating atherosclerotic ulcer of the popliteal artery, which I didn't really mind because then I was about to stent. And if you look at the images here of the stent deployment, you can see how the stent now is completely deployed in a completely different way. So this very much, you know, matches with what we say. So just do it right the first time, because if I deployed the stent as it was before, then it would have been probably a nightmare, you know, straight after. And even if you positioned a balloon mounted stent, if you did something, then, you know, the supera stent would have never returned to the first let's say the nominal deployment. So I think in this case the retrieval of the supera stent was a good choice. We are about to publish our experience with 6 retrieval of stents, and you will see it soon, probably on General Endovascular Therapy. And I think it's a good trick if you're really in this kind of situation where you can't do anything else. So thank you for including my case, August, and go on, please, with all the other things. It's very interesting presentation.
Looking forward for that. So for the most complex cases, what we do is try to join the best of both worlds on what we call the PCP maneuver. So let me show you an example in a really complex case, heavily calcified plaque, coral reef. So we initially try to dilate it with a standard balloon, but as you can see, once we deflated the balloon, the plaque tended to collapse again, the lumen. So at this stage, we decided, okay, let's deploy a cover stent and aggressively balloon it. But as you can see on the screen, there were still some areas where the stent was not fully expanded. So at this stage, we used the pierce technique while maintaining the balloon inflated in order to fracture the plaque with both the needle and the external compression of the stent in a sort of synergistic maneuver. And as you can see, this is a highly effective maneuver since it not only achieves a full expansion of the stent, but also even prolapses the plaque. And in case this is the final result of full expansion of the stent, amazing outcome for a really complex case. And in case you still had a sort of residual stenosis, what we do is to perform the PCP extra support by deploying a super stent inside the former cover stent in a sort of dual reinforced layer manner. Okay, but what about if you're already in trouble? You have already your occlusion or your restenosis. I would say that the first thing that probably will come into your mind is why in hell I did it? Why you deployed stent? Because as you know, a recanalization of a non-occluded vessel is far easier than a vessel with a stent. And at that stage, I think that the most important thing is to be aware with your enemy. And thrombus is the worst enemy when dealing with reintervention or treatment of occlusions. And I will give you this advice, my best advice of these presentations, keep this quote in mind. It shouldn't be too easy, because if so, be careful, because it's quite likely that something is going wrong. So this is an example of an occluded stent, which is a nice reconstitution, distal SFA, nice runoff, a nice DP artery. So we took him into the OR, and the wire passed nice and easy, straightforward. So it was a Friday afternoon case. We thought, wow, this should be 1 hour case, go home. But unfortunately, we were wrong. Because as you can see, we had a distal embolization, not only in the P3 segment, but also all of the runoff of the forefoot. So as you can imagine, at that time, we were absolutely devastated. Why me? Why me? Because we had turned a claudican into a threatened limb patient. So we decided to try to aspirate the thrombus with a catheter, and luckily enough, we were able to clean up all of the thrombus, and this was the completion angio with a nice restoration of the flow on the forefoot.
How did you manage to aspirate all these thrombus then? Which device did you use?
We use a catheter. We use a 4 French catheter. But
great.
As you probably are thinking about, you may probably be thinking about this next step is my new advice. It's like, you have this sort of two easy, tricky cases, I would recommend to use your Rodriguez device. This is a really fancy device with a huge aspiration power. So this is a case in which we have an occluded stent. So we turn on our Rodriguez device. Once you arrive in a sort of stenosis, you can dilate it and resume your treatment. You need to go nice and easy to and fro, really gently. We used to keep the distal cap in order to have a sort of a natural embolic protection device. And then when we are done, we just go through the distal aspect with this nice outcome. For me, a really nice feature of this device is that allows you to treat fresh, really fresh, acute thrombus, and also long-standing thrombus, even months following your stent or thrombosis. So let me spend a couple of minutes talking about how to break into an occluded stent. So as many of you, our first attempt is always trying to knock on the front door with a curved catheter and a wire. But in case we fail, we keep on knocking, but in this case more firmly. And what you can do is just inflate a balloon, as you can see on the screen, because this will give you support and pushability for your wire, and not only support and pushability, but also it will center your wire, which favor the passage of the wire inside the stent. And if you fail, as Miguel Montero and Lorenzo explained nicely in the former episode, you can always knock on the back door with a retrograde puncture, because this usually makes your life a lot easier. Sometimes, as you know, it's a lot easier coming from below rather than to go ahead antegrally. And if all the above fail, we do what we call knock on the emergency door. And this is a case in which we couldn't pass, and as you can see, we directly puncture the stent, and I'd say that this is the easiest retrograde puncture of the Fem-Pop segment, since the landmarks are quite clear and you can switch your projection to see where is your wire. So the wire just go through and get into the rendezvous inside the catheter, and then in an antegrade fashion, you just cross nicely your stent up to the end of this stent. What about crossing the stent once you are already there? I would say try to use low profile devices, a control loop, be gentle, and always try to confirm your intra-stent position. And you can do that with different projections of your C-arm, or using extravascular ultrasound or IVUS. And how to exit an stent? I would say don't be in a rush, don't be rude, don't be rough, be gentle like these guys, in order to avoid thrombus dislodgement at the level of the distal cap. And if you have gone bidirectional, you will need to perform your rendezvous. And as you know, we have all of these techniques from the cardiologists, the card, the reverse card, the double balloon. I'm not going to spend much time on them. You all know them. I'm going to spend some minutes talking about alternative bailouts. So you have this outback re-entry maneuver, the repop, again described by Lorenzo. So what he did is just to progress retrogradely an outback, because he had went bidirectional, but he couldn't achieve the re-entry due to a former surgery at the level of the groin. So when both catheters are in parallel, he deployed the needle and the wire, and in this case, the wire directly lodges into the catheter, and then with this through and through, he deployed a super stent inside the former stent in a sort of presto-lag maneuver, really fancy, and with this amazing outcome. The second technique is the Fourli technique, and this consists in getting from distally in a retrograde fashion, getting at the level of the origin of the SFA subintimally. Then you inflate your balloon, which is going to be the landmark for your needle. Thereafter, you perform an antegrade puncture of the common femoral artery, facing the needle, steering the needle towards the balloon, and then puncturing the balloon and lodging a wire inside the balloon. Thereafter, you retrieve simultaneously the balloon and the wire, and then you have already connected through lumens, through subintimal, and through lumen again. And as you can see, following the stent deployment, this is an excellent outcome. And finally, you can also use a technique described by our group, which is a sort of homemade re-entry device. So as you can see in this example, we couldn't go intraluminal, so we decided to go subintimally. Unfortunately, we couldn't achieve re-entry, perform a retrograde puncture immediately. The wire as well went subintimally. So as you can see, both wires were pretty close, but could not connect them, probably different channels. So at this stage, what we do is to progress a snare from below, a snare from above, and then piercing through both snares with a needle, 21 gauge needle, and progress 014 wire. Then retrieve the needle, close and retrieve the snare from below, close and retrieve the snare from above, and we have already made the connection, the re-entry into the tool lumen. So we balloon, and then we also deploy our stent in a Presto-like technique, and the distal stent, post-dilate it, and with this excellent outcome. So time for the poll. Hand over to you, Lorenzo.
Yes, the third poll. So essentially, it's very impressive. Like you describe all these techniques, and actually, all of them maybe are useful for single patients. So sometimes you, for some reason or another you should be able to know all the tricks, and you're explaining us all of them, and it's fantastic because we're learning so much from you, and we thank you again for this great presentation till now, which is gonna end. But I would like to speak to you all day actually. So question number 3 then, in the meantime, for our audience: would you treat an asymptomatic focal in-stent restenosis in order to prevent an occlusion, what is called a graft salvage, which is very much accepted in general, in an open operation, but sometimes with the endovascular recanalization is not that accepted? So your answer is yes, the answer is no, or the answer is there's no point in following up these patients. And hopefully no one will answer C. Let's see. Let's see how we'll just please continue. Thanks a lot.
So you mentioned Tosaka's classification. Here it comes. So as you know, Tosaka wrote this nice paper and clearly established that if you have a Tosaka 3 and occluded in-stent restenosis, the freedom of recurrent in-stent restenosis and the freedom of recurrent occlusion is a lot higher if you are dealing with a class 3. This is why we're thinking about prevention. But what is actually behind a class 3? I was really impressed with this pic from Kostas Straboulakis, a first episode of Fem-Pop session, when he showed what is inside a stent. And it's difficult to believe that all of this material can be compressed or dilated with a balloon. So sometimes I wonder if performing an angioplasty or deploying a stent inside a stent won't end up in a sort of limiting the room inside the stent in what we call, and this is a tribute for you, Lorenzo, for your country, and forgive me if I pronounce it wrongly, the effetto lasagna. I mean, if you put a stent inside the stent, you will end up having no room at all. So I don't really think that probably this is the way. So probably for these sort of cases, the best way is to gain enough room. And you can achieve that with atherectomy in order to gain room inside your stent. And at this point, I should remind you that the only approved device for atherectomy inside the stent is the Jetstream from Boston Scientific. Let's go ahead.
Okay, next poll. Essentially, August, sorry to interrupt you, but I think also the Rotarex is approved for in-stent occlusions, isn't it?
Yeah, you're right. But I've considered, even though the Rotarex has a atherectomy property, I would say that it's not as strong or as any other atherectomy devices. So I would say that it's another concept, the Rotarex device, not for the bulking plaque or yes, for thrombus, of course, but tough plaque, I would not consider a Rotarex device for that sort of cases.
Okay, no, nice, because this is what I usually use in my experience. Also, but maybe we can continue later, maybe, but like the Jetstream can cause problems with stents which are not, for example, superior, can destroy the struts. So especially blades up. So we need to be careful in using that device inside stents, normal nitinol stents, because it can be it can become even worse. When you have not only the thrombus, but you also have a completely destroyed stent. Anyway, it's good. Then hopefully we're gonna discuss that at the end. So question number 4 in the meantime for the audience: what is your antithrombotic regime after endovascular treatment of an occluded SFA stent? So this is also important because we are not just operators in the lab. We also need to think about our patients later, and as we said before, how much do we check and how much do we prescribe the right therapy? So option number 1, single antiplatelet therapy. Option number B, dual antiplatelet therapy. C, anticoagulation, D, antiplatelet therapy, so maybe with aspirin plus anticoagulation, and as we have seen with the recent studies, rivaroxaban, low dose, and option number E, do antiplatelet and anticoagulation together. So also we need also to think about our patients, how much they walk, how much stable they are, but this is all up for discussion later. So in the meantime, thank you, August. Continue.
Okay, and finally, I would suggest always broaden your perspective, because you need to ensure an adequate runoff for a good outcome, because it's really pointless to have a nice, amazing, beautiful image of your stent, but having an occlusion in the BTK segment. So my last advice, if you are dealing with a really complex case and you don't have a full armamentarium available, have a chat with your vascular surgeon, because sometimes a timely retreat is a victory and a nice bypass with a good vein is the answer. But anyway, if you are still an integrist of the endovascular treatment, you can still pair QE by using the detour technique, which consists on deploying a stent, a cover stent from the arterial side inside the vein, tracking the vein, and then getting back inside the artery with this nice endovenous bypass. So last question.
Last question. Also, I want to mention that probably we are still understanding if it's going to be online in the next weeks. We're going to have Pierre Sandoval, who's Sanandon, sorry, who was a very nice skilled surgeon from France, who described the extra anatomical bypass, so endo bypass. So essentially, it goes out from the artery instead of going to the vein, which actually, PQ bypass needs to demonstrate to us, which is actually safe. It goes outside in the let's say perivascular space. It goes out, and then it connects the two segments which are patent with a Viaband. And actually now he published on Journal of Vascular Surgery his technique, and he will publish very soon his results on European Journal of Vascular Surgery after 3 years. So it's important also as a technicians, as a clinicians, as a vascular experts, we publish our long-term results. Because sometimes, even the case that they showed of me, this went down after 6 months. So they want to reline with the supera. So it's good to show good angiographic images, but also we have to be very honest with our final results. As we said, especially the Tosaka 3 are very difficult to be tackled. So think about bypass, and this is said by an interventional radiologist, so please believe us. So question number 5, how many endovascular redos do you consider reasonable for treating an occluded SFA stent? 1 through 3, these are the first 3 options, or as many as necessary, so 3 or more. And I think it could be also a good discussion about how many centers not only see the do of an SFA stent, but also the stent itself. How many times, endo first or open first. So anyway, let's keep it for the end. August, please conclude. Thank you.
That's all from my side. No tricks left. So thank you very much for your attention. You can join me in my social media accounts, or just text me or send me an email in my email account. Thank you very much, guys.
Fantastic. And actually, looking at you with your short sleeves, really, you don't hide any ace, and the only ace here is you. So very good, fantastic presentation. Actually, I enjoyed it so much. One of the best I've ever seen here on Vascupedia Fem-Pop edition, and I can tell you that I've seen quite some of these. So congratulations again. And actually, it's very nice to discuss also about these topics, because these are the most challenging cases, and everyone has different opinions. And there's a lot of literature supporting any opinion, so it's good as a clinicians to go through these cases, these results, and to chat about what we think is best for our patients. So let's start then from the pulse, so to listen to what people think about what you presented. So let's have the first poll. What is your primary revascularization method for long SFA occlusions? So stent occlusion, sorry. So POBA is 18%, DCB is 27%, and then we have stent grafts, so Viaband, let's say, for 9% of the people, and the majority of people are thinking about the bulking plus or minus DCB. So what's your take-home message from that?
Well, I think you have already mentioned the take-home message is there's no evidence at all. We have scarce data. To be honest, I was expecting to see the most popular answer like POBA or a stent. I'm slightly surprised because at least the bulking is not so popular in my country, but well, good to learn it.
I think it's good to have, because even in UK there's not a good reimbursement. So essentially this is what it is in US, and this is what is in Germany. So probably, you know, in these countries they are more used to. I still try to use the bulking and DCB. The fact is, like, if you look at literature, there's no significant improvement in DCB compared to POBA at 2 years. So this is also something to be taken in account. And actually what I really don't like is to inflate just a balloon, either DCB or POBA, and then you just squeeze this kind of gum, you know, from the most liquid part. And then what you just have the same gum that will get the same amount of water and will reocclude. And this is why also in the Tosaka classification, the results of simple angioplasty are so poor. We are waiting for, you know, some more data about the bulking and DCB. Am I right? What do you think?
You're right, definitely right. Yeah, I think we need to get rid of the gum.
The gum, yeah, the one that showed, you know, the picture from Costas showed very nicely. Okay, let's have a look to the second. Then, Paul, do you use the Kobayashi dissection classification in your daily practice? Answer one is yes, no is 70%. And 19% Koba watts, and I think it's also mine. You know, I went back actually to the you know, some slides of a presentation of mine, which I will share with you straight away. And actually, this was I took them from my good friend Adi Licha, and actually this is coming from 1985. It was reported from the cardiologist, National Heart, Blood and Lung Institute, coronary artery angiographic changes after PTCA, manual of operation. So essentially, this is nice, because I mean, I need to check the publication from Erin Armstrong, but it would be nice to understand, you know, how much these are similar, and also it would be nice to understand. You know, what people usually do. I mean, maybe they don't look at the classification, but maybe they go like, you know, they put their thumb and they say, more or less. What do you think?
Yeah, well, I think, to be completely honest, I have no idea if the spiral dissection is a D or E or whatever. But what we are already aware is that anything higher than a linear dissection should to be looked thoughtfully and have a really low threshold for prolonged dilations or spotted stenting. Regardless, we have seen, and I saw that in one of your presentations, that there's a paper from Japanese people with awful dissections that 1 month later have a nice outcome. But to be honest, I prefer to sleep well.
Exactly, you're right, and this all comes to do it right the first time, and actually, which is also, you know, it's in UK there's this GIRFT, so get it right the first time, which is like a proper, you know, group of people who are investigating on hospitals, not just of course on vascular, but just to try to do the things right the first time, and actually it's very good. So I just want to ask a question quickly to you. How much do you, because I mean you mentioned this classification, but how much do you consider, if any, the classification of Shamas, the one with the IVUS? So it's a classification that's gonna tell you know, the audience. It's a classification which takes in account 2 different parameters, and as you mentioned, one is how deep is the dissection, so intima, media, or adventitia, and then also how much of the lumen it takes, more or less than 270 degrees. How much do you think that IVUS could be important in this kind of assessment? And if I show you the question, you know, we're gonna go a bit random today because I feel very, very comfortable with you. If you can show the question which I put on the screen, there's Elias Rodriguez from Spain, and he's asked, which is your opinion regarding the use of IVUS to assess remaining lesions after treatment in SFA? Thank you. So just answer to this question.
I hope Elias is well. He's recovering from an intervention. So strongness. So I would say I wish I had the chance to answer the question, because I don't actually have IVUS in my own center. We're quite a humble center, no IVUS at all. But definitely I believe that IVUS will give us more information with regards to the hemodynamics. So definitely would have a role, but we have to keep in mind that there's an economic background associated to the use of IVUS as well.
But you said very rightly, do it right the first time. So essentially, if IVUS can show us, like Lichtenberg showed us in that picture that you post, that IVUS can change our strategy, probably is gonna save us some money. So talking about IVUS, you know, I'm not a big IVUS user, but I'm what I call myself an IVUS curious. So I think that the main utilization of IVUS in the future, it won't be for sizing of the vessel. This needs to be assessed, you know, before with some also extravascular ultrasound or CT or whatever, but it's mainly to understand better our long SFA dissection. You showed your case, fantastic one, where you thought, you know, there's a brisk flow. I love the sentences that you put up, you know, oh, such a good result, but then actually we are missing something. So do you think that IVUS will have a role in the future for dissections or not?
Yeah, definitely. And not only for the SFA area, we both are always looking farther below. I would say that at least at the SFA area, we have bailouts to manage dissection. This is not has been accomplished in the BDK area. So we can use stents, but not massively. So I would say they will definitely have a role, not only on the SFA, but also the BDK.
Okay, good, because this is also my feeling. So it's good that we talk about this. We try to understand, apart from also the, you know, what the companies want to sell us, what we want from the technology. So I think it's a good conversation which could have also in the next years. So let's go for the next poll then, a very interesting one. It says, would you treat an asymptomatic focal in-stent restenosis in order to prevent an occlusion? So treating the endovascular as a bypass, and 60% of the people said yes, 22 said no, and I'm surprised that 11% it says like quite, you know, polemic. There's no point in following up these patients. So these patients, what do you think about that?
Well, there's some people saying that probably dealing with this patient and with this follow-up, it's pointless because you end up having to perform your surgery with more or less the same outcomes. But I would say that being completely honest, we should follow the classification, the TOSACA. Saying that, I would say that we need to remind that the TOSACA classification was built up with just plain balloon angioplasty, as you have mentioned. I would love to have this trial with full armamentarium, debulking, DART, all of these things, and probably we will definitely understand if we need to treat them or not.
I think it's very wise. Actually, I think that if the patient comes back with more symptoms, for example, let's say the patient was a rest pain and comes back with some claudication, and then of course you try to stress them to come back if they have a worsening of the symptoms, because this could be really an indication of early failure or even, you know, medium-term failure of your strategy. So I think that I agree with most of the people. I would definitely treat that, because you can pass from quite simple to treat in-stent restenosis to a full stent occlusion, especially if you stent it quite a lot. Then you will end up having this kind of, as you mentioned in your case, threatened limb ischemia, because if there's then a good column of clot, then, you know, to deal with this, it's not as straightforward as a simple in-stent restenosis. So great question, I think, for our audience. So let's go for I think what is the last poll. And we have plenty of questions. So what is your antithrombotic regime after endovascular treatment of an occluded SFA stent? So no one goes for the single antiplatelets, and we see a dichotomy between people going for dual antiplatelet therapy. Probably these are cardiologists or people who are very much you know, anchored to the past. And then it's like, I love the 36% which are trying to follow the evidence, you know, with the Voyager trial, antiplatelet therapy and anticoagulation. So what's your strategy, and what would you suggest?
I'd say that I have a divide hack. To be honest, if we are dealing with normal restenosis, we just deployed a stent or just treated with drug-coating technology. I usually manage them with dual antiplatelet therapy. If you have any issue with regards to distal embolization or thrombus, remaining thrombus, definitely go to antiplatelet therapy and anticoagulation. But I don't know the right answer, to be honest. There's still a lot of to know.
Yeah, I mean, in UK, we are very much happy about using the NICE guidelines. So the national guidelines, UK people are very much patriotic and they like to use their own stuff. And actually, it's based on some sort of evidence. And, we are always discharging our patients on single antiplatelet, which is usually aspirin plus the rivaroxaban low dose. Actually, it's also interesting to see how many people are resistant to clopidogrel. So 30% of the people, despite we don't know, are resistant to clopidogrel, which is a huge amount of people. So 1 on the 3 patients are gonna go for a single antiplatelet because the second one doesn't work. So do we have more polls? I don't remember. Probably we still have one. Yes. How many endovascular? That's one of my favorites. How many endovascular redos do you consider reasonable for treating an occluded SFA stent? So again, there's many people saying 1, many people saying 2. No one is saying 3 actually. 3, they don't like 3, and many others say as many as necessary. So what's your strategy as a surgeon? I already shared my point as an interventional radiologist. So as a surgeon, what do you think?
Yeah, I think it all depends on the background of the patient. If we're dealing with claudicants, I'd say 2 shots, no more than that. Otherwise, I just will think about a bypass or even nothing, improving your medical treatment. But if we're dealing with critical limb ischemia with no chances to perform a bypass, as many as necessary.
Good. And actually, now I'm gonna reverse a question to you, and this is gonna be a hot topic. So, as an extremely skilled endovascular surgeon, what's the percentage of the people with SFA occlusion, let's say around 15 centimeters and above, that you treat with endovascular? And if you do any primary surgical approach, when do you do it?
Well, to be completely honest, I crossed to the dark side a long time ago. So I'm everything but a surgeon. So primarily I treat all of them endovascularly, and in case of failure, we'll see.
Okay, that's a good answer. I think that if you are good enough and skilled enough, many times you cross the lesion, so you don't create bad dissections, especially at the level of the distal part of the vessel, then endo first is a good option. We need to really think about, of course, to endo when there's no vein, I think possible. When there's a vein, I think that's still a good debate. What's best to be done? We are used to see bypasses which go on for 12 years. It's fantastic. I don't know if we can then claim the same. We don't have really many data of long train of stents after 2 or 3 years. So I think it's something. UK is very much eradicated, and I think it's not everything which is old has to be put in the bin. But I'm very much endovascular first, as you are.
And also, as I usually tell to my fellows, we have this P2 segment, which is there's no room for surgical treatment. So we can treat our occlusions up to the P1, P2 segment, not threatening a landing zone for a bypass in the P3 segment. So P2 is always, from my point of view, endovascular.
Yeah, that's a very good.
Directly from a Fem-Pop bypass P1 to Fem-Pop bypass P3 segment.
Yeah, of course. Also, you need to have a better vein, because if you don't have a good long vein, then you will end up with matching different veins, graft, surgical graft plus vein. It's not ideal.
Yeah, and the outcomes of the splice bypass are pretty similar at the endovascular. I fully agree that nothing better than the vein, but if you don't have a good vein, probably endovascular option should be.
That we all agree. And actually, we need, as operators, we need to be as skilled as possible to provide a good stent expansion. Because, I mean, as you showed in this wonderful CT, which I was amazed to see, it's not like endo. You can't say endo, because, I mean, it depends how much, how good your endo is. It's not like, you know, a bypass, it's still, you know, I don't want to make it simple, but it's stitching a tube or a vein from point A to point B, which actually they should be okay. When you do an endo, there are so many different factors that can influence your outcome. So it's very important to have the correct armamentarium and correct also the mentality. So let's go for some questions. We have many and we have a few minutes, but I will try to squeeze them all inside. So one is coming from US. So our good friend Kumar Madasari is asking us something very, let's say, American style. Would laser in multiple direction help clearing more instant restenosis, since you can potential direct all angles? What do you think?
I cannot say anything at all, to be honest, because we don't have a laser available in our country. So definitely this is coming from Kumar from the States, because there I know it's pretty popular, but not in Europe. I'm not really aware that many centers in Europe uses laser.
No, they're not. Actually, I think the first paper was described by an Italian guy who is from Rome, Roberto Gandini, and he was the first one describing the use of laser. But also in my center in UK, laser is not very much used. And also we should probably, I never asked myself why. I don't know if it's about cost, it's about evidence, it's about, you know, I would like to see what they do also in Germany, where atherectomy and the bulking devices are more used. But it's laser usually, you know, the Debra, for example, I've seen in many congresses, they go through the orange very nicely. I've never seen going through in stent occlusions, but it looks like very nice. And I know that in the US, they use it a lot. So please, Kumar, then text us some good links.
Yeah, Kumar, yeah, definitely. The concept of vaporizing the plaque, it's amazing. It sounds like, wow, but no experience at all.
Okay, but good. You know, it's also good to see, you know, we are here to learn mainly from our audience. So it's good also to give and take. And Kumar saying, lol, lol, lol. He's very happy to see. Yeah. So I would like to go for another question now, interesting one, and I think it's very much correlated to, you know, doing right the first time. According with leave as less metal as possible, which is your usual approach to treat SFA without stents?
Well, definitely, I try to keep it on that side. So I think the key point is trying to prep your vessel with a prolonged inflation time, slow, nice, gently, trying to avoid dissections. And then if you have any dissection, spot stenting. But yeah, I'm on that side, and leave nothing behind if possible.
So it's also good to see, you know, as you showed very wisely, if your recanalization strategy is intraluminal, subintimal, essentially if you are subintimal, different, I mean, personally speaking, I think there's very few long SFA, long occlusions from, you know, the origin to the Hunter canal are then able to be treated just with the normal angioplasty. I think it's very unlikely. If you go in the subintimal space, that means there's some disease which is quite significant. And so what's your approach? Let's say, let's create your August ISA algorithm. So like, if you're intraluminal, what you do? If you're subintimal, what to do?
Well, I'd say that if I'm interluminal following a DCB, I have a residual dissection, a spot stenting. Subintimally, I tend to deploy a super stent.
Okay, and my other question for you, what do you think about tack stenting from Philips? Again, it's something which is quite common now into the US. It's not very common in Europe. Do you think there's a space, and for which patients?
Yeah, I'd say that there's a space for these sort of patients that we have talked about, like spot dissection that you can just fix without leaving nothing behind. We don't have them available in my country as well, or probably not really amazingly used, so no experience at all, again. But probably that area, and I would love to have this sort of concept distally as well for these over dissections.
Definitely. Okay, that's nice. And what do you think then? So my last question for you about shockwave. How do you see that? It's nice to ask you. How do you feel this technology can help us? Could help us in like as a primary treatment or as a vessel preparation? How do you see the role of shockwave mainly?
Mainly vessel prep, I'd say, not a definitive treatment. And this again increases the overall cost of the procedure because you need to use your IVL, then your DCB or whatever, and plus minus stenting. So, but it's a nice tool. I think it's highly effective in specific scenarios. We still need to see what's going on with eccentric plaques, subintimally. I, again, would love to have that sort of tools distally. I would like to see what are the outcomes where we don't have effective treatments apart from piercing the plaque distally. So the main issue, and I've seen cases from Mariano Paen, just progressing the IVL inside the arch itself. So if we are able to progress our device and we achieve a good trackability, probably it probably will be a good tool. But for the Fem-Pop, nowadays what we use is pierce or just palming and cracking.
Okay, I think it's nice. But personally, for example, it would be nice to ask our audience how they see it. I personally see it as a sort of permanent treatment. Let's say, shockwave plus normal angioplasty. There was the data from the last randomized control trial, which was done by Shockwave, which shows minus 70% stenting in IVL treated lesions compared to normal DCB. So essentially, I think and this is a core lab adjudicated, so I think it's quite serious. So I mean, we're waiting for these answers. I think we don't have any certainty now, but it's good that companies also provide good data with randomized control trials, which are not, always the best answer, but, I think they can clarify, many of the obscure points. So last question for you, and then we can go and have, I don't know, in Spain and in Italy, usually we don't have dinner, but here in UK, they're ready for dinner. So essentially, the last question I put up is quite a simple one, and it just also to glorify one of the, I think, the most brave guys in our sector. So please, Giacomo, if you can put up the question of Chemto Joshua. I don't know where you're from, but it would be nice also to know which country are you from following us. So he's asking, can you put, Giacomo, can you put the question on? Are you still using Bolia technique? Amanda Bolia in 1989 described this amazing subintimal recanalization where no one was doing it. So what do you think? Do you, especially for a long SFA occlusion, do you go primarily subintimal? Do you try to go intraluminal? How do you escalate your wire? And then we can close.
Yeah, I would say that I escalated like intraluminal antegradely. If I fail, straightforward to the retrograde, trying to keep my intraluminal protocol. And in case of failure, again, straightforward to the subintimal. Yeah, I use the Bolia quite usually technique, but not the standard Bolia, and that's all. I think that probably you need, as you mentioned, some scaffolding or some bailouts just to deal with dissections or any complications that may happen.
So it's nice how you mentioned that you're going retrograde if you can't go intraluminal from antegrade, which is also my my approach. So big heart for you. Thank you for supporting me in this in this personal battle. But it's very difficult to justify that sometimes, with people say, why don't you go nice subintimal and destroy the whole vessel? I think it's very elegant, and I think I would like, us as guys who are interested in that to push for this kind of approach, which is very nice and very productive. And guys, it's already an hour. We're online. Time flies when you enjoy what you do, and actually this is definitely the case for today. One of the last episodes today was with August Isa. It's say in Spanish, like I need to come back to my roots, the Italian roots, Isa. And actually it was a pleasure to have you with us. It was a fantastic presentation. presentations, full of data, full of different tips and tricks, but also full of your personality, which is always positive, and it's always very important for us, for me especially, to learn from you, because we learn a lot from your videos online, we learn a lot from your humbleness, and we thank you a lot for having been here today, giving us the best of your cases. And with that, August, last message for our audience. We still have 30 seconds.
No, just like thank you very much for your kindness. It's been really a pleasure. So enjoy your summer, you all, and see you next year at Vascupedia.
Okay, see you then next week. Actually, next week we're gonna see what we are preparing. There will be probably a complication from my cases, so not everything goes always like you would like. And it's also important for us to share our failures and to learn from our errors, compared to just show everything is great, everything is fine, endo is fantastic and everything like this. So be prepared to next week, hot topic. And thank you, August, again for being with us. And I remember you all, Tuesday afternoon, 5:30 Central European time, it's Vascupedia Views time. Thank you a lot and see you next week.